the results. We know the results. But for EQA, the results are known once we get a feedback from the PT provider. And so the results are immediate for IQC, but in terms of EQA, the results are received later on. IQC can be done on an ongoing basis. In fact, for some of us who may be aware about monitoring and evaluation concepts, I would quickly say that IQC is more of a monitoring measure, while EQA is more of an evaluation measure, because you do it later, you do it periodically, not all the time. In terms of the concentrations, for IQC, you have probably the normal, the pathological low, the pathological high. And in EQA, you can have multiple concentrations across the cycles that you're participating in. Both of them checks precision and accuracy, but it's good to know that EQA also helps in assessment of linearity or confirming the linearity capability of our equipment. In terms of comparison, IQC only does for your lab. You're only comparing yourself, your equipment. But when it comes to EQA, you are comparing your results and others. So that is probably a quick difference between the IQC and EQA. Now, quickly into what are the requirements of ISO 15189 when it comes to IQC and EQA. I will be very brief because I really want us to talk about how to assess these clinical issues. Now, in terms of IQC, according to ISO 15189, is that one, we must have a procedure in place. We must be able to specify the QC acceptability criteria. We should also be able to consider third-party controls when we are participating in these QC programs. Remember, most of the QCs that we do are mostly given by the same organization that gave us the equipment, but sometimes they may not be very adequate. Again, for QC, we need to get materials that have the same matrix as patient samples. We need to have levels that cover the entire range, the entire testing range of our equipment. And we should also be able to define a frequency of testing that is based on both the stability and the robustness of our test method, but more importantly also based on the risk of harm to patients. Further into these requirements, the standard requires that we have to record them. We have to record the QC data in a way that we can be able to detect trends and shifts. And that is why most laboratories will engage in LJ charts and other kind of graphs to be able to know the progress of our equipment as we continue the testing. Just a minute. Okay, sorry. I have gotten a communication that I'm not very audible. Probably someone can tell me now. Am I audible enough? Is it better now? Before I proceed. Okay, good. Thank you. Sorry for those I may have left behind. The other requirement of IQC is that we should review our IQC data in a regular manner. That is to mean, if we do IQCs every day, then you have to also consider reviewing the IQC the same day, and in fact the same time. Because if you do an IQC now and you wait until 3 days after to review how the results are, it means that even if there are going to be problems, you can't know, you can't tell whether they were resolved. The review also needs to be in a time frame that indicates current performance, so that in case there's a challenge now, we can always be able to correct and see how to do it to make sure that it's not replicated to patient testing. Preventing release of patient results when IQC fails is another requirement, that we are not just doing IQC for the sake of it. If the IQC indicates a problem, then we cannot go ahead and continue running patient samples. We cannot release what we have already run up until we confirm that our equipment is okay and is able to release reliable and credible results to our patients. Another requirement is that Patient samples should be rejected when it is determined that they contain clinically significant errors, and particularly when IQC fails. And this is what we are going to be talking about in a few minutes from now. How do we determine whether the IQC results we are getting indicates of a clinically significant problem? Retesting of patient samples after we have corrected the issues in our systems should also be done to ensure that these clinically significant issues do not affect our patient, and also evaluating patient samples that were analyzed between just before IQC failure and the last acceptable IQC run. That is to mean, if I run an IQC now and it fails, even though I'm going to correct and make sure that everything is in order, the standard requires that we move back until when the IQC was passing, just to know when the problem began. We are going to be talking about that in a few minutes. When it comes to EQA, these are just some of the quick requirements of EQA according to ISO 15189 2022. One is that all our testing methods must be enrolled into EQA, including the point of care testing. So no tests should be left behind, whether it's a small test, as we call them, or a very complicated test. A procedure should also be documented for EQA, and we should also have make a point of involving everybody. Anyone who participates in testing or even in the pre-examination exercises should be involved when it comes to running of IQC and also EQA. You have realized in some laboratories, their staff will always be out on leave or probably out on some night duty, and in a whole year, they may probably not participate in the EQA. So we need to have a schedule, we need to have a program of how we can make sure everybody participates in EQA. And if our laboratory manager is not involved in doing EQA, then also I want to suggest that if the laboratory manager is not able to participate in EQA, then we should not let them do patient testing. Again, EQA samples should have the same matrix as patient samples, just like we said for IQC. And the people who are organizing your PT program, the people who are organizing your EQA should be able to fulfill the requirements of ISO 17043. This is a standard that guides how the PT provision should be done. And we as a laboratory also need to consider the target values that are being used by our EQA providers. So EQA providers, you see, they are just like examiners. Their exam is not a top secret. We need to know how they evaluate the EQA reports. We need to know which samples, which values were used to tell us that we are acceptable or not. And therefore, at the point of engaging our PT providers, let us also consider asking them, how do you evaluate your results? Is it by consensus? Is it by use of technical experts? Is it by use of reference materials? How exactly do you get your assigned values? That is something we need to consider at the point of enrolling into EQA. Just like IQC, we also need to do regular review of EQA reports. And this regular review should be done also in a time frame that provides indication of current performance. You don't get a report today and then wait until 3 months to go through it. Once you have done your EQA, follow up with your PT provider, let them share back the reports as soon as they can, so that you can go through the reports and see if there are any existing issues that you need to sort out before you proceed with patient testing. Other interpretation of this requirement is that as we continue doing EQA, also consider an EQA that has a higher frequency, so that you don't do EQA once in a year. Because if you do it once in a year, it means that all the other months, you don't have an idea of how your results are comparing with other laboratories. The other requirement is about taking appropriate action when EQA fails. And one of those EQA appropriate action, is to assess whether this EQA failure is actually clinically significant. And like you're going to see in a few slides, sometimes we beat ourselves so hard when we have failed an EQA. And you will come to realize some of these failures are not actually clinically significant. I don't say that you don't do anything about an EQA failure, but you need to determine, is it necessarily clinically significant? The issues you're having with this EQA failure, are they indicative of something that is clinically significant? We're going to look at that in a few minutes. The other requirement is about review of patient results that could have been affected and consider them for amendment, and also advising our users appropriately. So if you do an EQA today, then you receive the reports a week or 2 weeks after. The standard requires that we consider all the patient samples we released on this particular day that we ran the EQA, and see if this EQA failure could have been translated on patient samples and patient results as well. Now let's go straight ahead and talk about assessment of clinical significance of EQA and IQC errors. And just to repeat and to say it again, sometimes we beat ourselves so hard, sometimes we don't take appropriate actions, that even our patients continue, you see, to undergo clinical significantly errors in the result that we release. So once we have done our IQC and even our EQA, and we have received whatever outcome, and in most cases the failures, we need to ask ourselves, where is our patient? How is our patient doing if this is the kind of results we are getting from the EQA provider? So that's something that we need to consider even as we proceed with this webinar. Now, continue writing down your questions, continue telling us how we are doing. If you are not able to hear us again, go ahead and write on the chat box and we'll be able to adjust accordingly. Just to recap that IQC and EQA are usually performed to check the capability of laboratory testing processes to produce correct and reliable results. The reason why we engage ourselves into IQC and EQA is to check the validity of results. We want to know whether the results we are going to release to the patients are going to be credible, they are going to be correct, they are going to be precise, they are going to be accurate. That is why we subject our equipments, our testing methods to these IQC and EQA. But also to mention that IQC and EQA failure, because many times we'll do an IQC and EQA and it will pass. In fact, 80% of our IQC and EQA runs will be acceptable. But sometimes 10 to 20% of the times, we are likely to experience IQC and EQA failures. But we are saying EQA failures are not necessarily the problem. In fact, they are just indicative of some underlying problem in the testing process. And so when we are doing this IQC and EQA, the issue is not necessarily whether we passed or failed. The issue is, once we know that we failed, did we investigate to know what is the underlying problem? And not just looking at the underlying problem, but also checking where is our patient in all this. Remember, ISO 15189, especially the current version, is so patient-centric that anything we do, we have to really consider how is our patient doing. As we address them, you see at the reception area, as we type down their results, we need to understand how is our patient doing. Once we receive the EQA report, we need to ask our first question, how is our patient doing? Now, ISO 15189 2022 in clauses 7.3.7.3 and also 7.3.7.2 part G, G1 and 2, and 7.3.7.3 section H and I. These two clauses require that we check whether the EQA and IQC results failure are indicative of some underlying problem that may have impacted patients' results as well. That's what we are saying, errors that are clinically significant. So it's not just about doing the IQC, doing the EQA, initiating the corrections and the corrective actions, but also going ahead and asking ourselves, could this problem may have been translated to the patient results as well? That is the essence of this webinar today. Now, just to see exactly what the standard says, in part G of 7.3.7.2, the standard says that in G1, when IQC defined acceptability criteria are not fulfilled and indicates results are likely to contain clinically significant errors, those results shall be rejected and the relevant patient samples re-examined after the error has been corrected. That is very straightforward. It is clearly understood, you see, from the standard. But what we need to ask ourselves is, how do we check, how do we confirm whether these results actually contain clinically significant errors? The standard goes ahead to illustrate something close to what we have said in G1, that the results from patients that were examined after the last successful IQC event shall be evaluated. This is what I was saying, that assuming you do an IQC today and it fails, of course we go ahead and troubleshoot where the failure happened, initiate a correction, initiate a corrective action. Very good. But now the standard requires that we go back and ask ourselves, because the last time we did an IQC was yesterday in the morning, and yesterday it was passing, but today in the morning it is failing. When exactly did the problem begin? When exactly did these issues of IQC failure begin? Probably if we did the IQC yesterday at night or yesterday night, we would have realized that there is a problem with the equipment. But because we did not do it, we didn't realize. We have only realized today in the morning when we did the IQC. So the standard is requiring that we move back several steps until when the IQC was passing, just to recognize exactly when the IQC issues began. Now, 7.3.7.3 H&I, this is about EQA. It's about external quality assessment, where EQA results fall outside specified acceptability criteria. The standard is telling us that appropriate action shall be taken. Of course, this is to mean that when EQA fails, the right word is actually when EQA fails, we should take appropriate action. Now, one of those appropriate actions is assessment of whether the non-conformance is clinically significant. Of course, when you look at 7.5, clause 7.5 of the standard, and even 8.7, when the monitoring results go outside the acceptability criteria, and by monitoring here, we are talking about IQC and EQA. When they go out of the criteria that is acceptable, that is supposed to be called a nonconformity or a nonconformance for that matter. So we are told when that nonconformity happens, which is of IQC failure or EQA failure, then we should confirm whether it is clinically significant and particularly to the patient results. And then when it is determined that the impact is clinically significant, a review of patient results that could have been affected and the need for amendment shall be considered. Just imagine, you have done an EQA today. You submit your results to the EQA provider. Then they take about 7 days to give back your reports, only to realize after 7 days that you are actually failing. The results you gave out were out of range. The standard is telling us that we need to go back and check. On this day that we ran some patient samples and also EQA samples, and we have noticed the EQA is failing. How was our patient that time? How did our equipment do the patient results? So we need to check whether the errors may have affected the patient results and consider amending those reports, and also advise our users appropriately. Sometimes you may not have to amend. When the standard is saying the need to amend, it means that sometimes it is not logical to amend because probably the patient has already probably recovered, they have taken the medication and they are well. But for some tests, it may be appropriate to consider amending the report and issuing a report that is okay. Good. So how do we assess IQC errors now that I have told you all those stories? I want to describe it in form of a process because each stage of that investigation of the IQC failure is actually part of assessing the clinical significance. Number one is raising a corrective action request. And I want to mention this now that I have heard of many laboratories, and it's actually in one of the questions that you sent to us when you are registering. In some laboratories, they don't consider IQC or EQA failure as an unconformity. But it's good to mention that the standard says, just like I've mentioned a few minutes ago, whenever the results of monitoring fail to be within the acceptable criteria, that is supposed to be handled as an unconformity. And therefore, the first stage of assessing this clinical significance is by raising a corrective action so that you describe the problem, what exactly is the problem, what requirement was violated, and what evidences do we have for this particular problem. So for example, if it's about an IQC, you don't just say IQC failure. If you go to many laboratories in their corrective action forms, they just indicate IQC failure, but does not give the details of what exactly happened. So you need to indicate it like this. For example, give the details of the test. You see, platelets level 2 QC went out of range. And then you mention the requirement violated. So in this case, for example, you can say the 2-2S Westgard rule was violated, and the IQC acceptability criteria outlined the procedure for quality control was also violated. So make sure that you are, the way you document your problem or the IQC failure is elaborate enough to communicate and even to be used as a reference next time when you experience a similar problem. Number two is root cause analysis. And I don't want to go deep into root cause analysis because this is another concept altogether. And of course, we know that root cause is the principal reason why an unconformity happened, or the principal reason why probably you have an IQC failure or an EQA failure. And some of these root causes will actually tell us whether the nonconformity or the error is clinically significant. For example, if you establish your root cause to be deteriorated IQC material, if you establish that one of your root causes is deteriorated IQC material, at once you will realize that if the issue is only the IQC itself, it is likely that the patient results were not affected. Because the problem is not the equipment, the problem is not the calibration curve, the problem is not the staff, the problem is only the IQC itself. And therefore, we know from this point that this IQC failure is least likely to be clinically significant. But when you establish that the calibration curve was the one that was deteriorated, then at once you'll also realize that your nonconformity or your IQC failure is definitely clinically significant, because we know calibration will affect everything about the testing that we do. If you realize that the problem is about the inadequate staff training or handling of IQC, then again you can tell that this error is probably, so it may not be clinically significant. And therefore, root cause analysis is part of the process of checking whether our errors are clinically significant. Like I said, I don't want to go into the details of this because this is a whole subject altogether. But then the third stage in this process of assessing clinical significance is determination and implementation of correction and corrective action. So that now If the issue was, let's say, deteriorated IQC material, you'll go ahead and initiate a correction. For example, halt the patient testing and rerun the IQC until it passes, and then go ahead and initiate the corrective action by way of probably a refresher training or doing a memo to remind staff about IQC and EQA handling. And at this point, if the IQC passes after this correction and the corrective action, you just go ahead with patient testing for today. But now, that is not enough because you may also want, the standard also requires that we evaluate, this stage number 4, we evaluate the patient samples from samples that were analyzed just before the IQC failure until the last successful IQC event. And what we are saying here is, even though you are going to establish the root cause for today's problem, why the IQC failed, and you go ahead and initiate correction and corrective action, that is not the end. We are saying you have to go some steps backwards until when the IQC was passing. And these are now the approaches that laboratories are using. So some of these approaches, we have used them in our journey of helping organizations in the accreditation process. Some of them we have also learned from our colleagues in different organizations in different countries. You may agree with some of them, you may not agree with some of them. Now, the first one is assessing results by the patient's clinical history. For example, you have experienced an IQC failure today, and we are saying, it's only that we did the QC this morning, that's why we have realized there's a problem. If we did it yesterday night, we would have realized that problem last night. But because we did not do it, we have no idea when the problem began. So you can take a sample of a known diabetic case who is known. You see, these frequent patients who come for monitoring, you know that their results is supposed to be high. So you can go ahead and check, because they came yesterday at noon. How did we report their results? You may know a kidney case, a kidney person who comes for routine checkup and monitoring. You may want to know, because this patient always has high creatinine, how did we release their results yesterday? And that can help you know whether the problem that you're having today for the IQC began sometime in the course of yesterday. But one thing is that this method is not entirely reliable, and the reason being, you may have a diabetic patient who probably, because of how well they have managed their blood sugars, they did not record any high result. And so even if you are to consider their sample, you can't tell whether you release the right result because of how well they have managed their case. And so that is just one approach that we can use occasionally, but it may not be able to help us in all the cases. The other approach that laboratories use to check for clinical significance is one of comparing the currently failed IQC result with the last successful IQC result. So yesterday, you had a creatinine IQC reporting 100, like is indicated on the slide here. And according to our IQC ranges, that IQC was passing. Now today, we release a result of 115. And again, based on the ranges we are using, that IQC, we are going to say it has failed. And you see, the moment it fails, we have to stop everything and try to troubleshoot. But what we need to ask ourselves is this failure clinically significant? Is this result you are getting today of 115, yet yesterday we were getting 100 for the same IQC material? Is this difference clinically significant? That is what the standard is trying to tell us. Because like I said, we may beat ourselves so hard. We might even condemn the equipment because it is failing on IQC. But we want to ask ourselves, is this failure actually clinically significant? So how do you do it? Many laboratories have different methods. But there is the issue of calculating the standard deviation. I mean, the percentage deviation, sorry, not standard deviation, but percentage deviation between the IQC result you are getting today and what you are getting yesterday, even though it is failing, and we are going to address that failure in the, you see, the RCA and the Kappa way. But you want to know, how is our patient? Is this failure probably impacting our patient? Now, what you can do is to calculate the percentage difference by taking your today's results, which we are saying are not correct, and subtracting what you got yesterday. Then whatever result you get, you divide by what you got yesterday, because yesterday's correct, the results were correct. Then you multiply that by 100%. What you're going to have is now the percentage deviation between what you're getting today and what you reported yesterday. Now, what do you do with this percentage deviation? Now, if the percentage deviation is less than total allowable error, and I'm going to tell you about total allowable error in the next slide. If our deviation is less than or equal to total allowable error, we don't need to beat ourselves so hard. That failure, even though the IQC failed, is not clinically significant. So just go ahead, implement the correction, implement the corrective action, and review for effectiveness. So if an assessor on the day of audit is trying to ask you, did you confirm whether this IQC failure actually impacted patient results? You can use that percentage deviation to illustrate, to demonstrate to your assessor that the failure, yes, happened, we did something about it, and we can confirm it never affected patient results. But if the deviation is greater than the total allowable error, the failure then is considered clinically significant. That means yesterday, when you did your IQC, the problem developed in the course of yesterday and probably yesterday, and that problem may have affected patient samples. So you need to go ahead and review patient results that were done between yesterday and today, and probably consider, amending or have a discussion with your clinician on how to do now that you have realized about this issue. But again, these methods may or may not be completely okay. It may not be relied upon all the time. Because now, remember, we are just comparing the IQC that we did today and what we did yesterday. You see, yesterday in the morning, today in the morning. How about during the day and at night? So it does not satisfactorily capture the condition of our testing system between the times between the two IQC events. That's the only difference, the only challenge with that method. But it can always give us an indication. Now, before I proceed with the other approach, it's only fair that I illustrate or maybe explain the concept of total allowable error. In many places, they just say total error allowable, whatever arrangement of words you want to use. Now, this is the amount of error that can be tolerated without invalidating the medical usefulness of analytical result. And it's good to realize that these total allowable errors are not values that we are coming up with. These are studies that have already been done across the world by different organizations, and they have established, because of these biological variations that we can have between one test and another, and because of these differences between the analytical methods, there's a likelihood that even if you were to do a test now and repeat it the next moment, you may not be able to get the same result. But how should the difference be? So we are told there is that allowable error, a quality requirement that sets a limit for combined imprecision and bias that are tolerable in a single measurement or single test result to ensure clinical usefulness of our test. Like I mentioned, these are values that have already been established for all the parameters you know about, and they have been documented and published on different websites, and you can go ahead, participants and colleagues, go ahead and check out those websites for the different total allowable errors for our parameters in the laboratory. Now, going back to the approaches, the third approach, remember the first one we said we are relying on the clinical history. The second one, we said that we compare our today's QC with yesterday's quality control results. Just a minute. And now the third approach is rerunning a patient sample that was previously analyzed before the IQC failure. I don't know whether the way I explained it there is quite understandable, but there are two options here, or even more. You can use even more options. We are saying you have an IQC that you ran in the morning, it failed. But yesterday you had run another one, it was passing. And I want to repeat myself, sorry for repeating myself, the standard is requiring that we confirm when the problem actually began. And we have explained two approaches. Now the third approach is now the one we are saying, we run a patient sample that was previously analyzed before the IQC failure. So what you can do, you can rerun representative number of samples that were reporting borderline results. For example, you ran a blood sugar last night, probably at 1 a.m. and you are getting 9 millimoles per liter for blood glucose. And you have realized today in the morning, actually, the analyzer we are using for glucose testing has a problem with glucose. So you can go back to that particular sample, rerun it now that you have noticed the IQC failure and you have already corrected the issue. Rerun it now and see whether you'll be able to get the same result. Probably I gave a wrong example because I know for glucose, it may have deteriorated, so it may give you a different value. But consider another test, probably a creatinine, probably a test that is not, you see, does not deteriorate over time. So rerun that sample that you had reported last night today, after you have corrected your IQC, and see what kind of results you are going to get. Now, in some laboratories, they don't go with the borderline results. They rerun just a representative number of samples that were analyzed in the last 1 hour before IQC failure. I really hope I'm not ambiguous in what I'm saying. You have run your IQC now, you have realized the failure, and you have agreed the failure did not happen now. The problem did not start now. It could have started 1 hour, 2 hours, 5 hours, 12 hours ago. So how do you know, number one, when the problem began? Number two, how do you know which patient results were affected before you realize the problem? So what many laboratories will do, after you've run your QC, it has failed, you have corrected, and you now requested to go back, you go back like 1 hour, the first 1 hour before the IQC failure, so that you see, I ran maybe 20 samples before this IQC failed. Let me run 2 or 3 samples and see the results I'm going to get now, whether they compare with what I was getting in that 1 hour. And you can tabulate them. You can tabulate them in this manner. So you have probably 2 samples, or maybe 3, or whichever number you decide in your procedure. So sample 1, for platelets, for example, before you ran your IQC, you are getting 145. And after failing on the IQC and you repeated, you are now getting 150. Okay? Another sample, before the IQC was failed, the IQC failed, you are getting 460. You ran the IQC, it failed, you corrected. After repeating that sample, you are now getting 480. And you can tell the 2 results, there was some bias on the lower side before you realize the problem. So again, how do you know whether these results are different or not? You can go ahead and calculate your percentage deviation again. so that you take the results that you are getting before you recognize the IQC failure, subtract with what you are getting now after you have recognized the IQC failure and troubleshot and corrected. Then whatever result you get, you divide by what you are getting now, because you believe what you are getting now is correct because you have already corrected your IQC, and then multiply that by 100%. Now, again, if the percentage deviation is still going to be less than the total allowable error, then we will say it is okay, we failed, the IQC failed, but the failure was not clinically significant. Even if you reported for this particular patient, probably the one who has 150, and you're getting 150 now, but you reported it to the doctor as 145. Even if you reported 150, the patient is likely to be managed in the same manner. For this second sample, even if you reported for 80 instead of 460, you still be our patient will still be managed in the same manner. That's why we are saying, even though there's some difference, in the two results, the difference is not clinically significant, and we should not beat ourselves again so hard. So just go ahead, implement the corrective action, monitor any actions you take, and review for effectiveness. But if the percentage difference between what you are getting, you see at night, and what you are getting now is way above the total allowable error, then we'll say that our failure in IQC is clinically significant. And for that reason, you have to review the patient results and probably discuss with the clinician and consider the need for amending those results. So if it's a patient, you release their sample at night, you gave their result as 120 for creatinine, but after doing some repetition, now that you have corrected the issue with the IQC, you get 100. You may probably want to discuss that with a clinician. And if you agree, you can go ahead and amend, or you can just agree, let the clinician manage the patient in the best way they can. And so that is how you can assess the clinical significance of IQC. Now, finally, almost finally, for assessing EQA errors, the process is the same. You start by raising a corrective action request. You do a root cause analysis. You determine and implement correction and corrective action, and then you go ahead and assess for clinical impact, like we said in 7.3.7.3 part H and I. So how do you go about it? Remember, the standard is telling us that we have to compare. We have to look, now that the EQA has come out that it is failing, has that failure also been translated to patient results? So what you can do, one of the approach that you can use is to compare the reported EQA value with the PT provider's assigned value. For those of us that are already doing EQA, that may be easy to understand what I'm saying. For those of us probably who have not participated in quantitative EQAs, this is what happens. The EQA provider is going to share similar samples to different laboratories, and every laboratory is going to give out their values. Now, one of the labs, our lab for this matter, gave out the value as 120 millimoles per liter. But the PT provider returned the report saying, no, we failed. The value was not supposed to be 120. Actually, the mean was supposed to be 124. And when you look at the range, we are actually out of range. So what are we supposed to do? Calculate the percentage deviation between your result and what the PT provider was giving. It is true you could be failing, because you see, the range for this particular material would probably be something like 122 to 128. Okay, this is what we are getting. This is the range from the PT provider. And for us, we go to 120. we need to ask ourselves, how far are we from this particular range to say that our values are something that we need to really beat ourselves about? So you can go ahead and calculate your percentage difference, compare that again with the total allowable error, and if it is above, we are going to say that error is clinically significant. If it is below, we are going to say it is not necessarily clinically significant. The other approach is rerunning representative samples for the patient that were tested on the day that EQA samples were analyzed. I know this may sound quite illogical because you run an EQA sample today, and our EQA provider is going to spend 7 days, 10 days, 15 days. Some EQA providers might even spend 30 days. Now, where will we get the samples to repeat with? Because we usually discard our samples every 7 days. So what I'm suggesting here is, on the day that you are running your EQA samples, and I may want to hear what the different laboratories are doing, you may consider that probably to keep some samples to be used for repetition later on, just to confirm that the patient samples were not affected. Because in this approach, what you're supposed to do is to rerun a representative number of samples that were tested on the day that EQA samples were analyzed. So you ran so many samples on that day. Probably in laboratory, you run probably 50 samples in a day. And among those samples, you also run your EQA. Now, you need to confirm to any assessor or anyone who is trying to check your quality system, whether on this particular day, when you run your EQA and it fails, whether our patient samples were also affected on that particular day. So what do? You rerun a sample. Probably that time you reported it as 10. But today, after doing your corrections of the equipment, you are getting 13. You want to ask yourself, is 13 and 10 clinically different? Are those two values clinically different? And so what you do, you calculate your percentage deviation between the two values. And once again, you compare that with the total allowable error. And so those are the two approaches that you can use for EQA or assessing errors that are recognized from EQA results. Now, quickly, in the interest of time, how do we handle these clinically significant errors? Because sometimes we realize these errors are also affecting the patient samples. These errors are not affecting patient samples. So for these ones that affect patient samples, the ones we are saying are clinically significant, how do you address them? So number one is halting further patient testing until the corrective actions are determined and effectively implemented. In some laboratories, I know this can be quite a tall order. I don't know for what reason. You want to do IQC, the IQC results are telling you the equipment is not okay, but we always find a reason of, going ahead with patient testing, even when we have known the IQC is not performing well. So I suggest that, and even the standard requires that when IQCs are showing failures and the errors are actually clinically significant, go ahead and halt testing until you have corrected and confirmed that these corrections are actually effective. The other way to handle these clinically significant errors is establishing the cause of the underlying testing process issue. Remember, we said we ran IQC and EQA to recognize or to establish which underlying issues could be there. And then retesting of patient samples can be another issue, especially when you have run an IQC today and you have realized that there's a failure, and this failure probably would have been detected yesterday, but it wasn't because we didn't run an IQC. You may be required to rerun some patient samples, and you can start with those samples that are falling somewhere in the periphery of the reference ranges, just to make it easy. I know it can be quite an expensive affair, and you may not want to, repeat all the samples. You may probably pick a few samples, repeat, and see whether that error was being translated even for inpatient testing. Now, the other one is having a you see, a very elaborate discussion with our clinicians. Let them know that for sure, even though we are trying our best to release reliable, correct results, there come a time when our equipment are not obeying us, are not obeying our procedures, and they are releasing erroneous results. And so we need also to have an agreement of what do we do? How do we proceed with these EQA reports, these IQC reports that are not okay? And they may also suggest to you, is it okay to amend the report, or we just leave it and then the patient, the doctor will manage the patient the best way they can. And like you're saying, consider amending the affected reports. So this is what you will have to undergo if you, by any chance, failed in IQC and EQA. And therefore, for us to prevent that, because no one wants to, halt testing in a busy laboratory. No one wants to retest patient samples. No one wants to have this very uncomfortable discussion with the clinician about amendment of results. So that we don't get here, what we need to do. And that is where I want to end this webinar at. So number one, these are things that we know, but probably it's good that we remind ourselves that number one, we need to regularly maintain our testing methods. And maintenance is not just what we have our engineers do. Many times we rely on maintenance done by engineers, and we ignore our daily maintenance that we're supposed to do. You will find an equipment, you see, full of alarms and error messages asking you to please do this maintenance, do this cleaning, but we ignore it. We continue doing our testing as usual, only to realize later that there is actually a problem now from the IQC. If only we had done this maintenance yesterday, cleared all the error alarms from our equipment, we will not have experienced a failure in the IQA or in the IQC. Number two is proper induction and training of new personnel. And we have realized many laboratories employ laboratory staff in a hurry. So you are employed today, and tomorrow you're on the bench, you see, doing what the other staff have been doing for the last 3, 4, 5 years, and you're expected to do it without errors on the first day of employment. That may not happen. That may not be realized. So let's take time. Let's take a day, 2, 3 days. Take our new staff through our processes, and particularly on handling of IQC and EQA, and we'll have it very easy when dealing with these clinical issues. Effective competence assessments. Many laboratories, especially those that are accredited, they will tell you that they do competence assessment, but sometimes this competence assessment is usually done, you see, to complete some forms. It is not the real checking of the capability of a person to address 1, 2, 3 issues as pertaining to IQC and management of our laboratory results. So it's good that we go ahead and do the right thing. Let's do a proper competency assessment, especially after induction and even after training and even after every year. Let's confirm that our staff are able to handle IQC. So that is it. And then practice brainstorming during root cause analysis, corrective and correction and corrective actions. Don't assume that you know the root cause. Don't assume that you have been in this laboratory for the last 5 years, and so you definitely know the root cause of this failure. Let's engage discussions amongst our team. Let's engage, have sessions when we can discuss the root causes for failures of IQC and EQA. And when we are reviewing our IQC and EQA also, let's consider the West Guard rules so that we're able to detect trends and shifts. Before the results show that there is a problem, we have noticed it from our West Guard rules. So that is probably where I want to stop at. Those are the ways that we can consider, to prevent this clinical impact when it comes to IQC and EQA. And it is at that point that I want to stop and thank you very, very much for listening to me. I know many of you were probably working, but you took some few minutes off so that you can listen to us. We do not take it for granted. I know most of us are still sleeping from the different countries where we are coming from. Others I know are probably on their way home. But we really thank you that you took the time to listen to us and yeah, to learn one or two things that pertains to IQC and EQA. So thank you very much. Over to you, Makati.
Thank you so much, Paul, for that enlightening, informative session. I'd like to take this moment to thank everybody for their contribution. Thank you for adhering to the request to continuously keep posting your questions in the chat section. Unfortunately, I just have about 15 minutes to wrap up the session, but I'm going to open the floor and allow at least 3 questions from the attendees. So I'll take 3 questions and then I'll also just pick 3 questions which I think of technical importance from the chat for Paul to respond to, which I think would require a little bit more clarity. But in terms of other questions that were posed in there were a few that I felt that Paul did touch on and did address during the presentation. So I'd like to open the floor to allow and take a few questions. So I'm just checking. So I do have one question from Daniel Koma. Daniel, please do ask a question. May you please unmute and ask the question. Okay. While he's struggling on his side there, may I ask Lydia, I have Mutoni, to please also ask a question. So may you please unmute and ask the question.
Probably Makati. I know we are still trying to learn this new system. We are having a challenge.
Okay. Okay, I think we are having
a
problem unmuting.
yeah,
okay,
sorry
so while we are trying to deal with the technical glitch, I'm quickly gonna go and address some questions that were addressed in the chat. So I'm just gonna pick a few of technical importance that I think maybe Paul can address quickly. Paul, please, if you can, in the most, quickest way, try to answer the questions. So one of the questions from Collins says, please advise on how to handle an IQC failure attributed to random error. That is, you perform a rerun and the repeat run is acceptable with no intervention. Would you still evaluate the patient results since the last acceptable run? Can you take that one, please?
Oh, okay. Thank you. Random errors are are the most difficult root causes in our laboratories, but they require a lot of monitoring. So I will not say there is one way, one single formula of how to handle the random errors, rather than, you have rerun and it is now okay. Run the patient samples, but then keep a very close eye until the problem is resolved. In most cases, they are out of our reagent, they are because of the instability of our equipment. So you have to keep monitoring. So monitoring, Makati and Collins. Thank you for the question.
Okay, thank you for that, Paul. And then the next one that I'm going to ask you is the question goes, you have QC material that is still within the expiry date. So I did see quite a few questions coming through regarding the expired QC material. And the question goes, however, when running the QC material, it fails to meet the expected results. How should one proceed with the situation? And then I'm going to couple it with the next question that says, with IQC material that is still within the expiry date but past half-life. If the material passes, how do you address such? I think they wanted to say if it fails, how do you address such? Yeah.
Would you try to recap the first question? Sorry, I probably missed it out. The very first question.
No problem, Paul. It says you have a QC material that is still within its expiry date. However, when running the QC, it fails to meet the expected results. How should one proceed in this situation? I suppose this is after performing a rerun or a repeat test.
Yeah.
And the second one, Paul, so sorry to disturb you. The second one also, you still have IQC material that is within the expiry date, but past the half-life. Now, the material fails. How do you address that as well? So I just coupled those two questions together. Over to you.
Okay, so you have an IQC material that is still within the expiry date, but past in its half-life. The IQC material still passes. How do you address that? Okay, let me start with that last one. I know, like for hematology, these CBC analyzers, they will tell you that the IQC has to be used within, let's say, 14 days. So after 14 days, you cannot go ahead and use the IQC material. So first of all, it's good that we adhere to the manufacturer's instructions, the guidance. When they tell you that after 14 days, we cannot assure you that the results we are going to get are okay. So even if it is passing, please know that it is passing by God's grace. If the equipment has a little other problem, you may not be able to get that passing. And remember, if it fails and the manufacturer has already guided you that don't use it beyond this particular period, then who will we blame? So let's adhere to the manufacturer's instructions. There was the other question you asked. You have an IQC that is still within its expiry date. However, when running the QC, if it fails to meet the expected results, how should one proceed with this situation? That happens all the time. In fact, most of the QCs that fail are within the expiry dates. But because of so many reasons, which you cannot be able to exhaust here, that's why we are recommending that you do a proper root cause analysis. The IQC fails. So go ahead as a team, halt the patient testing, don't be in a hurry. Trying to ask yourself whether you are going to do it by 5 whys or by the fishbone diagram. Try to ask yourself, is it about the equipment? Is it about the personnel who ran it? Is it about the storage? Is it about the environmental conditions? So I may not have a straight answer on why IQC fails, because they're going to fail for different reasons at different times. Makasi, any other burning question?
Thank you for that.
So many of them.
I apologize. I'm not going to be able to address all the questions. We did get quite a number of questions. I'm just going to go around trying to see which ones. So they're also asking about where they can source the clinical total allowable errors. Where can they get the information for different tests? Do you have that information to share, Paul?
Okay, good. So like I indicated on the slides, there are different sources for these total allowable errors. And once we share with you the slides, you can go all the way to page, I think page 30, is it page 30? No, page 27. Go to page 27. There is Westguard, there is Data Innovations, there is Pismile, so many other bodies that can do provide you with information about total allowable error, but they'll get it in the presentation.
Okay, thank you. And Paul, how many reruns can one do? to render QC unacceptable?
Interesting. So we advise that once you run your QC first and it fails, you don't repeat until you have investigated why it failed in the first time. So it's not about how many times you rerun, because rerunning is not the only way to investigate why the QC fails. So once it fails, investigate, try to understand the reasons why it might have failed, act on those reasons, and then you can go ahead and repeat. If it fails, you still have to go back and again. But it will depend on each laboratory's procedure. There are those laboratories who will say, once we have tried about 3 times and we can't see any improvement, then they are going to engage the supplier or the application specialist of that particular equipment. So it depends from one laboratory to another.
Okay, thank you, Paul. I'm just going to ask you 2 more questions before wrapping up. So you did touch on the impact on the clinical significance. And I think from what I gathered, the questions that came up in the chat, I think most of your examples were based on the quantitative tests, your chemistry, your hematology. So a lot of people are asking about the qualitative tests, like how would you how would you assess the clinical significance of the failed IQCs on qualitative tests?
Okay, very good question. I may have been biased on the quantitative test because that is where it gets complicated sometimes. That's where many laboratories get challenges from. But just to mention that whatever we do for quantitative should also be done for qualitative, probably in a different magnitude, probably without a lot of calculations and percentage differences and such. But probably, let me take an example of a HIV test. You have received your EQA and it is showing that you have an unacceptable HIV report from the EQA that you ran. So of course we'll go ahead and start the process from, you see, recording this as an unconformity, doing a root cause analysis, and establishing why this problem might have happened. Now, if you realize probably that the failure happened because of reasons to do with the reagents, and probably it was a particular batch of reagents, you can try and take another batch. Probably you have received a different batch of the HIV test kits, rerun some of the samples that you had released probably a week ago. And if your results now and the ones you gave out last time are not agreeing, you have no choice but to amend or to advise the clinician appropriately. And I'm saying HIV because now this may probably be a chronic condition. This is something that the patient is going to stay with. So if you are getting different results from what you issued last time, you may have to advise the clinician that, I'm sorry, we may have to recall the patient. Let's come probably and do a repetition. So it's only that you not engage yourself in a lot of calculations. It's just about comparing what you are getting now and what you are getting the other time. If they're not in any agreement, you go ahead and do the amendment for the same as we discussed with the clinician and the patient.
Okay, thank you, Paul. The last question that I'm going to address is, we had the very first question says, when ISO 15189 says the EQA provider shall fulfill ISO 17443, does that mean for all schemes that the EQA provider provides, it must be accredited? This was a question from Amelia. Do you want to touch on that?
Okay, thank you. Now, I like it the way the standard sometimes tries to be silent on some of these issues. They don't want to come out very strongly that the EQA provider you engage must be accredited, but they just tell you, the PT provider you engage must fulfill the requirements of ISO 17043. That, of course, indirectly tells you that the PT provider must be accredited. And one thing they have also done, they're not talking about necessarily the PT provider themselves. They are saying the PT program, the EQA program that you engage in must fulfill the requirements of 17043. So to answer directly, yes, the EQA provider you engage must have in their scope of accreditation all the tests that you engage them for. They cannot be accredited for HIV, and that is what they are telling you. And you engage them for TB, microscopy, for example, and they are not accredited. That may not sit well in as far as ISO 17043 is concerned.
Okay, thank you for that, Paul. I think that's going to wrap up.
Okay.
I would like to thank you, Paul, and Rankwell Consulting Group
Probably just a
for
minute.
this session that I found to be so enlightening, informative, and insightful. And then as we conclude, I just want to wrap up the discussion. You know, our key takeouts from this session was that IQC and EQA are key quality indicators that directly influence the reliability of the patient results. So it's critical that you take note what your results are, and when the results are out of range, what you do with those results. So you should never view them as an isolation or dismiss them as a routine variance. They need to be approached, you know, looking at the clinical relevance. You need to do your root cause analysis so that you can know how to prevent this, you know, from occurring again. And then you need to look at it as continuous improvement. You know, when you implement things like your Westguard rule, it does actually assist with you monitoring your QC systems to check whether your IQC or EQA, you know, is out of range. And then just gonna say, as a reminder, that quality assurance is not only just a checkbox, it's a commitment to excellence for every single lab that is performing patient clinical testing. So with that said, I would like to thank everybody for their participation, and then thank you, Rankel Group, and then may you continue running and providing such sessions. I think it's an opportunity for everybody to learn. We have a lot to take out of these sessions. And then there is going to be another session that Rankel will be providing soon. If you can put it up on the screen, they will be providing an ISO 15189 implementation virtual training, which will be taking place on the 4th to the 6th of June. And it will be an all day, an 8 to 4 session. And I'm hoping that they can share the poster. And then for everybody that has managed to register for this session, we will try to share the poster with you so that you can register and participate. So I would recommend the session for labs that are implementing, for labs that are recently implemented ISO 15189, the 2022 version. So with that said, any last words, Paul, from your side before I close the session?
Okay, thank you, Makati, for doing the recap so well. I really want to take this opportunity to thank everybody who turned up for this webinar. Like we may have mentioned earlier, this was our very first webinar since we got accredited by the Kenya Medical Laboratory Technicians and Technologists Board as a CPD provider. And we are looking to have more of these sessions. I'm sorry I took so long. I did not allow you more time to ask the questions and have them answered. But we are looking to improve day after day. And so in the next session, probably we make it smaller so that we can take more time to answer the questions. Otherwise, if you still have a burning question, our lines are open. Our email is open. Our WhatsApp number is open, the one for Rankwell Consulting Group. and my WhatsApp number is also open. Kindly feel free to share any question, and I'll be able to answer it on person-to-person manner. Now, just like Makati has mentioned, we have an upcoming training on ISO 15189. It's going to be a totally virtual training, like you can see on the poster, on this same platform. And we expect to go deeper into these requirements of ISO 15189 2022. And so we'll have a pre-test virtually, we'll have a PowerPoint presentation virtually, we'll have breakaway sessions virtually here in the same platform. We will have case studies discussed, questions and answers discussed in details, and also have a virtual post-training test at the end of it all. So we welcome you, all of you. We'll share this in our social media platforms. So feel free to like our pages, feel free to follow us on LinkedIn, on X, on YouTube, on Facebook. Think of any social media, we are there. Follow us and we'll be able to engage you from there as well. Ask us any question and we'll be happy to engage you once again. Otherwise, thank you very much. May God bless you and may you have a blessed evening and weekend. Over to you, Makati.
Thank you, Paul. From me, it's been an absolute honor hosting the session. I have a lot of takeaways as well, personally, from the session. And just before I go, a special mention to Abel. I did see you, responding to a lot of questions in the chat box. So I really appreciate that. Thank you for that. And again, thank you for all the attendees, for your participation, your questions. And as Paul has mentioned, the recording will be made available, the slides will be shared, and then you are welcome to contact Rancor for any additional information. So from me in Johannesburg, thank you very much. Thank you. Bye.
Thank you. Bye-bye.
Mm-mm.